Hi, everybody. Welcome to the Facility Management and Sustainability Breakout Room. My name is Clark Reed, and I will be your moderator in this session. I work in the U.S. Environmental Protection Agency in Washington, D.C. as a program manager in the Energy Star Commercial Buildings program. And many of you probably know this program through, if nothing else, that little blue Energy Star logo. It identifies the most energy efficient consumer products in the country. And Energy Star also is identifying the most energy efficient buildings in the country as well. Energy Star certified hospitals, for instance, use 30% less energy than their peers on average, and they emit 30% less greenhouse gas emissions than typical hospitals. And so our mission, besides identifying these very efficient buildings and these environmental leading organizations, we discover the best practices that are being used by organizations to save energy. And when we share those broadly across the sector in hopes of moving the market. I've been working with our Energy Star healthcare partners and the American Hospital Association for 25 years. And over this time, we have worked collaboratively to address all sorts of challenges that hospitals experience when they improve their energy performance. Equity, I think you'll agree, is a new facet to the environmental sustainability equation, and I'm really glad to see it on the table for discussion. So we've been asking a lot of equity questions ourselves within the Energy Star program. Now, it's probably been about a couple of years since we first started this. So for instance, we're asking questions like, how can we position Energy Star to better target underserved communities? How can we leverage the market to make energy efficient products more affordable to low income families? You know, the double paned Energy Star certified windows that you can get are typically not affordable to low to moderate income families. So what are the options? Well, we have worked with manufacturers to create affordable interior windows that can actually cover existing windows and help stop the drafts and the leaks. And we're also working on our distribution and our distribution partners to increase our marketing channels to these low to moderate income communities. My side of the program in commercial buildings is actually a little bit more challenging because we work not with families or consumers, but with businesses and organizations. So how should we address equity? So we asked our commercial buildings partners what they're doing, and I'm happy to report that one of them has addressed equity, I think, in a very significant way. Duke Realty recently launched their first community solar project in New Jersey, which will provide power to about 1,200 local families. And if you're not familiar with community solar, it sort of operates like a subscription service. If you're in an apartment building or if you're in a house that is not suitable for solar for any variety of reasons, you can subscribe to a community solar array, and you can use solar as if it were like on your rooftops. And Duke Realty their role is very narrow. They are just a solar host facility. There are other partners that are developing the array, recruiting into that membership, and administering the program. But get this, half the power that is generated by these arrays will go to low income families that will purchase power at a savings of anywhere from 10 to 15%. So I'm going to come back to this later, but as we can see, equity has very many facets. And I look forward to hearing from our panelists and our audience about how they are or would like to address these particular issues. So, so now what I'd like to do is ask our esteemed panelists to introduce themselves and tell us how their hospitals are addressing equity. And Sarah, I'd like to kick the introductions off with you. What's yours?
Thanks, Clark. Hi, everyone. Thank you so much for being here today. I'm excited to have a great discussion with you. And I'm not sure if we're supposed to do this, but at some point, I think it'd be great if we all came off of or came on to camera if you can when we enter the Q&A part. It's so fun to be able to see people if possible. So my name is Sarah O'Keefe. I'm the Director for Sustainability and Environmental Stewardship at a public hospital system called the MetroHealth System in Cleveland, Ohio. We're on the north coast of our country. A lot of people don't know we have a north coast. We don't think of it that way. But a couple of things about what we're on equity work. As I said, as a sustainability director, it's really been an amazing journey the past 4 years to work in a public hospital. Our hospital is an essential services hospital. Anybody who needs services walks through our doors and gets it. 2/3 of our patients are Medicare and Medicaid patients or uninsured. We have a large academic campus and 2 smaller community hospitals, plus a rehabilitation hospital right down the street. And one of the things that we have been prioritizing the past 2 years is the social determinants of health. I know that a lot of other campuses, a lot of other hospitals and healthcare systems are also moving this direction, right? Thinking about primary care, thinking about the 80% of determinants that influence health outcomes other than actually being in a hospital or a healthcare facility. So what we have been doing is one of the ways we have actualize this priority is by creating the Health Opportunity and Partnership and Empowerment Institute. So that's Institute for Hope, HOPE. And we work to address the social determinants of health by screening patients for the social determinants of health and intervening when needed. We have a very high percentage rate that I don't have for you today, but I'll put it in the link, the report for our Institute for Hope as a follow-on to this conversation. But we screen patients and then we create, improve, and align programs to combat the health disparities that we find within those screenings, within those patient populations after the screenings are done. We also work with our community partnerships and entities on the front lines of community health and well-being to connect all of this. Now, as the Sustainability Director, Environmental Stewardship Director, what I do is I try to connect those specific social determinants of health to our environmental stewardship. For example, one of the major influences on social determinants of health is your physical environment. And what can we do as a healthcare system and also a large community anchor in a neighborhood that has extreme health disparities, chronic illnesses, economic and education deficits? How can we leverage our physical environment actions and operations to address the social determinants of health as an anchor institution? So that's one of the ways that we are doing that. And I'll turn it over to the next person. I think it's Andy from CommonSpirit.
Thank you, Sarah. Andy?
Hey everyone, I'm Andy Woommavovah. I'm the System Director of Energy and Infrastructure for CommonSpirit Health. And if you'll recall, CommonSpirit is a 3-year-old company that was created by the merger of Dignity Health and Catholic Health Initiatives. And in my role, I am focused on CommonSpirit's infrastructure. And I saw some of the earlier comments. You know, there's been a tough time on getting things justified for capital investment with infrastructure. So we're still kind of looking at that challenge across our global footprint in CommonSpirit. But so I'm kind of representing your facility managers and directors, the folks that are in the boiler rooms and in the control rooms that are kind of focused on keeping the lights on and the air going. And for us right now, and for me, it's kind of a education for those folks that are out there on really how they connect with the equity piece in climate action. And they don't really understand. They do now as we start to kind of make them aware. But, you know, in the past, we've heated and cooled with just brute force. It didn't matter, you know, what we were doing because we weren't really thinking like that. Now we are. So now we have embarked on this kind of global education, if you will, on making our maintainers aware of the second, third order impacts of what our equipment's doing to the climate. Unfortunately, we've got some capital backlog that we have to address, but right now it's more of an education piece for us, so we can really understand what's going on. And then with my job on infrastructure, I'm starting to overlay the improvements that we can achieve with the infrastructure. And I'd like to just make a quick comment. I wanted to take issue with what Dr. Jeff said earlier, that some of that stuff's boring. I represent those folks that it's not boring to. We really want to be able to get that investment into our building automation systems, into the building controls, because those end up being some of the low cost, no cost investments that you can start doing to improve your output. And when we think about the climate and what we measure in 3 areas. We measure in scope 1, 2, and 3. So our facilities folks have a major role in that scope 1 piece, which is what we do with our equipment in our hospitals, and that scope 2 piece with how we're procuring the energy from the grid. So getting a better understanding of that. And now we know what better questions to ask when we're out procuring, and also what kind of contracts we're looking for to make sure that we're including renewable types with the energy that's coming into our hospitals.
Hey, thank you, Andy. Brian.
Yeah.
Hi, everyone. I'm Brian Chesebro. I'm an anesthesiologist in Portland, Oregon. And I also serve as the medical director for environmental stewardship for the Oregon region of Providence Health. And Providence is a large health system. It spans about 53 hospitals across 7 Western states. And historically, there's been a long-standing focus within Providence on environmental stewardship. But over the past 2 years, this focus has really accelerated, largely stemming from kind of the leadership's realization that as a healthcare provider, we occupy this unique position, both as an anchor institution in our communities, but we contribute, obviously, as many people have already said here, we contribute significantly to climate change, air pollution, and watershed issues locally. But we're also caught in this vicious cycle where we contribute to this pollution, but then we're called to care for the most vulnerable and those that suffer the effects of this environmental degradation. And that care delivery just keeps this cycle going and going. So really our program is focused on trying to break that cycle apart. It not only encompasses mitigation of our impacts, but it also really recognizes and addresses the resilience of our healthcare delivery system. So we've talked a lot, you've heard people mention, becoming more energy efficient, but we also need to be resilient enough to withstand the changing environment that our facilities are in, and that we go to work in, and that our communities live in. The Western wildfires of 2020 and the Pacific Northwest heat dome this past summer made it very clear to us that we're all vulnerable, but particularly those who are already suffering from baseline health disparities. So our work is really across 3 broad pillars. It's mitigation, it's adaptation, and it's advocacy. There are several layers of governance within Providence to facilitate all this, including an environmental justice collaborative, which is a multidisciplinary group that focuses on the ways in which climate change and environmental pollution disproportionately impact our vulnerable communities. And this group also works to ensure that environmental justice principles are incorporated into the broader strategies of Providence. Within Oregon, I personally feel really fortunate that our environmental stewardship program and our team is incorporated into the population health program. Again, highlighting the link and the importance of addressing climate and environmental sustainability through this lens of population and community health. With that, I'll kick it back to you, Clark.
Hey, Clark, if I may, real quick, I want to make a really great connection here with what Brian talked about. It's those cases and what the environment's doing to the elderly, to pregnant women and children, the disabled. Now we're making our facility directors and managers and maintainers connect to that. Before, they didn't realize the global impacts of what we're doing, but we're making those connections now, and they're having these huge aha moments saying, oh my gosh, I didn't know that. then you start to engage them, and they become this all in for the folks wanting to participate in this climate action plan.
Just spoke at a little online conference and.
Hi, we've got, yep, thank you. Yeah, thank you, Andy. Yeah, absolutely great connection. You know, it seems like the more broad we can make the discussion, the more allies we can have in actually getting you know, these broad upgrades happening and progress made on reducing pollution. So thank you all for those introductions. To our audience, welcome. I'd like to invite your questions by going into the chat at any time. But however, I'm going to ask that we're going to hold off on addressing those questions immediately, and we're going to try to hold those for the last 10 or 15 minutes of this panel discussion. So I'd like to start us off by sort of going back to Jeff Thompson's story about how Gunderson Lutheran came to address the climate crisis. And I'm wondering, we heard Brian talking about how the wildfires in Oregon and in the West, this past summer seemed to catalyze a lot of effort around addressing these climate issues. Do our other panelists, Andy, Sarah, do you have any other similar stories about your healthcare systems, or what events crystallized new action on addressing climate in your community?
Yeah, I can start if you would like.
Sure.
One of the things that really spoke to the need for thinking about resiliency, especially in our community, was the polar vortex of 2014, the winter of 2014, especially in the Midwest. That was an extreme event, weather event. And for MetroHealth, our campus, we are about 180 years old here. And at this particular campus, one of our buildings is very old infrastructure. What happened was we had frozen pipes, flooding, the loss of 200 beds. As I've already explained, we are an essential hospital, so it was really essential that we maintain our operations, and we really nearly had to shut down that winter. This, luckily, we did not have to do that. That led to an in-depth facilities assessment of our campus and a really broad community discussion of what is our role in the community as a hospital, as an essential hospital, and where should we be and what should we be doing. Basically, this led to what's called we should stay in the same location and rebuild and transform our campus. So that created a campus transformation department where I sit actually, and my job was created as a part of this transformation movement. And basically this $1 billion grouping of projects for our main campus includes the building of very highly energy efficient buildings and a new central utility plant that decrease energy use by 50% compared to our current buildings. And then we will be certifying WELL and LEED for these, but we also are going to reimagine our campus from a 52-acre built out physical environment, like hardscape environment, to about 25 acres of green space, which, as we all know, is another way to really mitigate the impacts and be more resilient to climate change. But it's not enough for us to transform just our campus. We looked broadly as an acre institution into our community, and we're leveraging our existing community collaborations to think about resiliency in the neighborhood, and using the eco-districts framework, which the eco-districts protocol, that's ecodistricts.org, has these 3 pillars of climate protection, resiliency, and equity. And those are both social, economic, and physical environment related. So that's one of the events. And as we know from climate change, especially in the Midwest, our number of storms is going to increase, the intensity will increase. So thinking of stormwater, infrastructure, et cetera, all of these things have really led to us being more resilient in our campus transformation.
Great, thank you, Sarah. So, the environment certainly has been a catalyst for taking action. We've heard about wildfires in the West. We've heard about the polar vortex in the Midwest. Now, health equity is another reason. And, I know equity is a new term for many of us. So I want to be sure that we're all clear on what it means. So equity is not the same as equality. Both are different as in terms of my understanding. So in terms of treatment, let's say, equality can be defined as treating everyone the same by providing the same levels of support regardless of their varying starting points. Equity, on the other hand, is giving everyone what they need to be successful by providing varying levels of targeted support. So while the health impacts of climate change don't fall equally across our population, right? Some population will be more vulnerable than others. Our response to that impact can be equitable by providing varying levels of support to maximize the number of communities that are able to weather the impacts. So I'd like to ask our panelists, Andy, let's start with you. How broadening the conversation on equity, how might that help hospitals take on more climate mitigation projects or do it quicker? You know, I mean, because it's not just about saving money anymore, is it? It's, you know, community benefit is another motivator for hospitals, especially in the nonprofit ones.
Sure, thanks, Clark. So I'm going to take it from kind of a little different angle, but it's still going to address how CommonSpirit is making a difference. And first, what we have done is we've set goals. We set goals for our output. And our CEO, Lloyd Dean, he took a team to Glasgow this year, and they committed to reducing our operational output by half by 2030. And by 2040, we plan to be net zero. So when you take those bold goals into account and you start reverse planning from there, it becomes vitally important that we're able to streamline the work that we're doing. So what we've done is we've embarked on a climate action planning program with a third party where we're identifying all the opportunities that are within CommonSpirit Health in those three scopes to be able to reduce that. And then parallel to that is an aggressive education program. So we're making folks aware of the inequities created by the greenhouse gases that we're producing. And all of that work requires us to figure out how we can make impacts quick. So what we've done is we've started a very aggressive retro commissioning program within CommonSpirit Health. And what that does is that creates low cost, no cost opportunities that end up going on a scorecard to allow you to do things with just adjusting sequence of operations with your equipment. When things are on and they're not supposed to be on, you're able to program to go off. So it's starting to create the awareness and doing all these things that we can do quickly to reduce that footprint that we're creating. But I think most importantly, we got to have that kind of top-down support for the program. And if I may share a quote from our CEO, Lloyd Dean, he said, "We believe there is an unbreakable connection between the health of our planet and the health of our people. Our net zero commitment supports our focus on addressing the underlying causes of health inequities, from access to clean air and safe drinking water to the effects of extreme weather, with a goal of creating a healthier community for all." And by our senior leader taking that stance, it trickles down to all of the verticals that are in our organization to make sure that everyone's doing their part now. And then for me and the facilities folks, it's once they gain an understanding of how we can create a positive impact, they're going to be all in. But it's to me, it's messaging, it's understanding where we stand. Dr. Jeff earlier stated that, you know, U.S. healthcare is 10% of the output in the U.S. That's huge. So we're going to do our part, and then we engage those that want to on our teams that want to do their part also.
Thank you, Andy. So when you justify doing upgrades in a hospital, you have traditional metrics to measure those. You've got ROI and you've got payback period and net present value. A lot of the other ways of justifying these upgrades are somewhat intangible, or at least not easily quantified. So are there ways in which you can quantify the health impacts of energy projects? Sarah, would you have any opinion on that matter?
Yeah, I think that there are, I feel like I hear a lot of people say it's the right thing to do, but that is not quantifiable always the right thing to do, right? And in the situation that a lot of other hospitals or organizations are in where they don't yet have that declaration that Andy just spoke about, which is amazing, that automatic connection, that top-down, trickle-down thing that's happening there. I think that there are a lot of tools, especially through the organization that Jeff Thompson mentioned, Practice Green Health. There is a very specific tool that they offer for free. You do not have to be a member. It's called the Energy and Health Impact Calculator, and we will share that link after we're done, but you can also Google it and find it. And they ask you to, I think, enter your name and organization in there. But what it does for healthcare organizations, hospitals specifically, is that they basically, you enter energy use data, and then they do a calculation of the kinds of energy, based on the kinds of energy that you use and where you are. They use energy from the Environmental Protection Agency and the Department of Energy and other peer-reviewed data to basically estimate the negative health impacts and healthcare costs that are caused somewhere, maybe not in your neighborhood because you don't have a coal plant right in your neighborhood, that are caused somewhere by fossil fuel energy use, as well as the benefits of energy efficiency. Really, the cleanest form of energy is the energy not used, as I feel like keeps coming up in this conversation. But also, if you were to convert a portion of your energy use to renewable energy, what the impacts might be on those incidences. So it's really if you're looking to start a conversation with, I've used this tool to start a conversation with our facilities management team and our supply chain, because it hits some of those more tangible things that, look, I can assign a number to this, and here are all the assumptions that go along with it. And even if we're not generating those negative health incidences, or they even have, what do they call it, medical incidences, like how much it costs in terms of ER visits based on your energy use, which is kind of amazing, then you can at least start the conversation. Like, what we're doing, our choices really do have this impact. So our choices as facilities managers, procuring energy or being more energy efficient, as Andy said, that you can really make a very quantifiable, tangible connection between the two. Great conversation starter. I will also say that on this website, they have a PowerPoint template that has speaking points for how to make that connection even more tangible. Bringing in the community benefit, if you are a hospital, a nonprofit hospital, has that requirement to have a community benefit report and do a community health needs assessment. We don't have that requirement, but we still do a community health needs assessment with other hospitals in our county. So I've certainly used that as a conversation piece as well.
Yeah. Hey, Clark, another real quick note there. One thing that I wrote down on something that Dr. Jeff said earlier was a disciplined disregard to conventional criticism or thinking. And that's what's going to have to occur as we think about how these projects are going to be funded that cost more than they used to. But also, we got to think that anything that we do today, any piece of equipment investment, we're going to be living with for the next 15 to 20 years based on the life cycle of that equipment. So we have to evaluate all of those things when we make that decision and not let the kind of the value engineering thing take out all of the benefit. Excellent point.
So once you have set your goals, how do you track them? How do you, what's a reasonable goal to actually set for your hospital? Is it going, net zero in 5 years? Is it something less? And what are your thoughts on public goals? Brian, you want to kick us off with your answer on that one?
Sure. Goal setting is really, really important. And if you're not in an organization that has an overarching goal like that, you're totally within bounds to set your own, local goals. I talk to people about like working within their sphere of influence and looking to see where your greatest area of opportunity is. And there's nothing stopping you from setting your own goal. Once you meet success with your own goal, that success should be communicated and celebrated up the chain. And before you know it, your leaders are paying attention, and hopefully you can convince them through other conversations with more team members to start to commit, to make a commitment. And Providence also has made a commitment to become carbon negative by 2030, which is inspiring and intimidating. But in service to that larger goal, then it becomes a matter of, well, where are you? How do you assess your current performance, and how do you use your current baseline to inform toward a reasonable goal, and setting an ambitious goal in 2030 and then working backward, and having that goal be championed by the upper level of leadership starts to change the value proposition in conversations, such that people do care about how much things cost, but they also care how much carbon is that going to generate, and considering the total cost of ownership, like Andy just mentioned, and changing the way we think about value, and bringing environmental impact on parity with financial impact over the total life of the building or the purchase or whatever it is culturally what we're trying to do. Getting data is difficult. Consolidating the data in one place is also difficult, and we're trying to work on that to create a dashboard and a central repository of environmental stewardship data, which we can share with leaders, to have that so that it's available for review, not only by the leaders, but by other caregivers, because this really helps engage people through increasing the visibility and the accountability of this work.
So for your buildings goals for your hospitals, do you have a particular tool that you use to track the energy?
So we actually passed the data through. So all of our building invoices across all 7 states go to a central service run by Schneider Electric, and they manage a tool called Resource Advisor, and they collect all of our invoices, and they hold that data, and we're now pulling it back out to merge it with specific Providence data to normalize against to do an internal normalization against energy efficiency and consumption and all of that. So it is a lot of work. But we do see the real benefit to having it internal and easily accessible to all of our leaders to continue to drive that engagement.
Andy,
and we do something very similar.
Yeah,
Sorry,
go
just
ahead.
to chime in. We do something very similar to what Brian was describing. We use a third-party system that collects all of our data, pays our utility bills, but then we have that go through Energy Star Portfolio Manager for our reporting through what's called the 2030 district, which are available nationwide. So if you're in this group, have never heard of a 2030 district, I encourage you to look it up, because you might actually have one in your area that you can join.
Great. Thank you, Sarah. We do have a few short minutes left. I think everyone probably saw the same message I did about going back to the main room soon. So I'm wondering if we should probably address some of the chat questions. So I am wondering, Kara, if you've been following the chat questions, do you have any questions that you can pitch our way?
I was just going to go back and look, and I just was noting, I can take myself off video, that Lois said that Ascension has joined CommonSpirit and Providence with net carbon and net zero waste goals by 2040. So that's fantastic to hear. We got the question about what tools are being used. There's several questions about benchmarking tools that have been used. And I'm not seeing, going back a little ways, there's been some comments on building drawings and things like that. So feel free to keep asking questions and continue the conversation.
Sure. Okay.
There was one about rural hospitals, actually.
Yes, I did see that one.
Maybe.
Yeah.
And I don't know if Andy can speak to that, if your system has rural hospitals. Ours does not, so I can't really speak to that one, but I'm not sure if your system has that rural critical access.
We do. We have several states with rural critical access hospitals, and And we kind of look at them through a little different lens because of, they're critical. And historically, they've been underinvested. So they kind of have floated to the top of our list on making sure that we're tracking and measuring their performance. And that's kind of where we are right now in CommonSpirit as a large system now. We have just finally got to the point where we've baselined our hospitals so we can focus in on who needs our help. But critical access hospitals are definitely toward the top of that because of how old they are and how long they've been underinvested. Typically, they have equipment that doesn't perform well.
I'd also just add again that, the critical access hospitals, they are absolutely critical. And they also tend to serve, vulnerable and underserved communities. So they are really at the sharp end of the spear in terms of responding to the adaptation to climate or environmental problems, and the need for those to invest in the resilience of a critical access hospital is critical.